Hello? Ignazio.
Hi, how are you,
Fine,
Dr.
what about you?
Sasha?
Hey, sorry,
Are you
can you
okay?
hear me? Yes?
Yes, I can listen very well. Thank you for this lecture. This is very important for us because your knowledge is a new knowledge, and we learn about your expertise and your tips and
Thank you.
tricks.
Thank you very
Thank
much.
you.
Thank you very much. Thank you,
Uh,
Ignazio.
we are meeting with the fellow in in our hospital, our fellows, and there are people from Bolivia and different parts of Latin America too. And thank you, Dr. Sasha Agati. He's a great man, great humanitarian sergeant, and this is very important for our field. And if you want to be, keep going.
Yes. Thanks, Ignazio, because for me it's a real privilege to be here, to be invited by you. And on behalf of the Congenital Art Academy, I hope we will continue to work together and plan a future meeting and sharing experience because we really trust that is very important to share experience.
Yes.
Um, Today, I would like to share with you our experience in patients with hypoplastic left heart syndrome, where we decide we use a hybrid approach in our center. So thanks again and regards to all the people that are connected, and it's a big pleasure and enormous opportunity to share with you our experience. When I start this job was again very hypoplastic left heart syndrome was more considered as a cancer, as a tumor. And it's very difficult to understand the genetic basis of most of the congenital heart disease. And I work in Germany with Professor Haas, and one day he told me, Sasha, that look at this. This was a child that from a very, very long time was founded, and they make investigation. They were very surprised to find such a disease very early. So we can say that hypoplastic left heart syndrome is not a new disease in congenital, but we can confirm how this represents a real long story about this amazing and complex and challenging defect of the heart. I love this picture because every time I share this with my colleague, and I think this is very important to uh, not classify but define very well, very clearly. When we talk about hypoplastic left heart syndrome, Bob Anderson say that this is not a real syndrome, as you know, you know him better as me, and he like to say that is more disease of the heart. And on the other side, we can clarify. I want to stress the concept because every time in our ICU or sometimes out with a cardiology, they say hypoplastic left heart syndrome. It's very important to define and to see which is the type of patient we are going to treat. And we understand, we realize from the big experience of the people that are that start to work with this disease, how the variant mitral and aortic atresia really represents the most challenging disease. But most of the time we apply these terms, this definition, to a lot of disease in the similar spectrum. So I would love again to stress the concept that the real hypoplastic left heart syndrome is the patient with mitral aortic atresia, not with, because we saw this also in our experience. They are completely different in terms of outcome, in terms of post-operative care, timing, all the definition, all the time, all the strategy we put in the field of this disease. We can say that the hypoplastic left heart syndrome is conceptually represented by mitral aortic atresia. And on the other side, there is, of course, additional group of patients who has open valve. So both mitral and aortic can be open, and this is a different type of patient. So it's important when we talk about this population of patients to clarify which type of patient we are discussing for. This is a sort of fast review of what we can do in single ventricle physiology, single ventricle pathology. And of course, today our more interest, our topics is on aortic flow obstruction, because these represent, of course, the prototype of the hypoplastic syndrome. And at the same time, we have to understand that we have to share that we apply the same surgical technique in different anatomical disease. And this is very important because, again, when we prepare, when we discuss, when we plan for a patient, it's important to understand what we need to, what is the goal of what we are going to do. Again, this is something that is rhetoric. It's all over the world knows that management for hypoplastic left heart syndrome cannot start during fetal life. I think that there is a bit of confusion from this point of view because we are collaborating with a colleague from Austria, Professor Tulzer, and he clearly demonstrate and show us the case of patient that they treat with fetal approach. And of course, the main disease that we can treat during fetal life is severe aortic stenosis, or of course moderate, or where the ventricle is suffering a lot during fetal life. There is no fetal treatment for hypoplastic, in my knowledge, in this moment about the hypoplastic left heart syndrome. There are very few recent experience in the atrial septum stenting during fetal life to relieve the obstruction of the pulmonary vein. But I think it's a very experimental and very starting experience. Of course, we go to our normal approach, and we know very well that the main point is during neonatal management is to establish a control of the pulmonary blood flow. And of course, we can choose according to our experience, according to our place, cardiology, system, all the things, which is the best option for the patient. I want to say that if in 2024 we are still talking about the best or the option for hypoplas, it means we are not really reach final results, a stable, shared and unique treatment like for tetralogy, like for transposition. We are still talking about which can be the best management for patients with hypoplas. So again, most of the people loves to do Norwood as a first stage. Most other one use Sano. They are fantastic, and I think that it depends on the center and other approach. There is, of course, the experience of Boston from Professor Del Nido about the left ventricular recruitment, but again, we are not discussing about hypoplastic left heart syndrome. We are discussing of a spectrum of the disease. So what is the goal we have to reach for this patient? The most important things, we need to have two pathway that can be unobstructed. The first one is the systemic blood flow. Of course, we have to have direct connection between the single ventricle and the aorta, and of course the coronary, and of course the the brain, without any kind of obstruction, because we know very well that every obstruction can be a failing of the procedure. And of course, probably is underestimated. There is the unobstructed pulmonary veins to the ventricle. This is something that probably we forgot, but most of our patients can have pulmonary vein stenosis, pulmonary vein obstruction. It means degree of hypoplasia of the pulmonary veins. Of course, it's very clear, it's anecdotic. We know very well that there is several options to make to join these results, BT shunt, the stent of the PDA, or of course the Sano procedure, or the last one, of course, using directly the native pulmonary valve. Ignazio asked me to talk about, I don't want to, most of the world knows very well which is the standard procedure or what we can do for hypoplast. I would love to share with you what we do with this patient and why we do and how we reach there. The first things that I think that our unit start with 4 ICU bed and hypoplastic left heart syndrome treated by Norwood or by Sano procedure. It takes, of course, in my hands, most of the colleagues can make some comments. It takes long time during ICU stay. So we were not happy to have our ICU bed covered for a long time. So since the start, I went and he come visit us, Professor Galantovitz, and we build our program based, of course, on hybrid suite, and we have a dedicated unit. It means with follow up with pre and post and interstage treatment. We decide, of course, to start this program, knowing very well that how the hybrid procedure is not something easy. It's very easy, but can be very easy from surgical point of view, but it's a very long, again, interstage period, and it's the understanding of this patient is not easy. We realized that in our experience, most of the children with this diagnosis was born in hospital. So we don't lose time to make them an overflow. So we prefer to do this procedure on day 1 or day 2. And we have a rule. This is coming from the Columbus experience. We try to use inotropes before the procedure. It's simple because we learned that super active, the inotropic effect on the heart can be can make some mistake during bending and standing of the pulmonary artery, the PDA. In the last 20 cases, coming from this long 10 years experience, we were able to extubate children in OR, most of them, or again, 4 hour postoperative. I prefer to use a very small approach, so we don't use too much chest drain and pacemaker wire or peritoneal dialysis. And we will talk about the rapid ICU bilateral bend. I'm a surgeon, so I would like to share with you some technical and some issue about the procedure. Thanks, this picture come from Dr. Gabriella Ricciardi that I asked to help me in this. So my idea, coming from the experience again from Professor Galantowitz, is to use the left pulmonary that most of the case is smaller than the right pulmonary in this disease as a fix with a fix bending that in all of the case was a 3 millimeters Gore-Tex shunt. During all the case, we treat we bring the patient to the theater. We open the chest, full sedation, no inotropes, good potassium level, no hyperactive heart, no inotropes, and we start with a 3 millimeter Gore-Tex shunt. We saw that when we use only one bending, saturation is not moving too much, and we see most of them, of course, they are with the 100% saturation despite 21% VO2 on ventilator. So I think there's can be not stupid, but something that you say, why you don't use this? But in our experience, we use the left pulmonary arteries as a modulator, as a fixed modulator of the palliation. And about the right pulmonary artery, again, we don't have a fixed number of BT shunt according to the weight of the patients, but of course we base our choice with according to hemodynamics. So as I say, very low hemodynamic impact when you put a bending on the left pulmonary artery, and no additional states usually required in this case. And we use a 3.5, 4 millimeters on the right, trying to keep our saturation up to 90. But we wait because this patient is in overflow. So you cannot expect that you put the bending and you have immediate results. So we put tourniquet and we wait, and we see generally we don't use 3 millimeters on the right. So we generally use 3.5 or 4 millimeters. We wait with for stabilization, and then when we are happy, we see, of course, natural increasing of pressure on the systemic pressure. And as you see there, most of the case we use 3.5 millimeters. But I want to stress this point because this makes this, if we have a patient with the inotrope, with adrenaline, it's very difficult to choose the right bending at the time of the procedure. You need to have a patient that is completely, most of them has a 45, 40 to 45, 50 systolic pressure at the time of the bending. And then you see that the systolic pressure go up and saturation will slowly come. Of course, it depends case by case at the level that you desire. Of course, between 80 to 85, no more than 90. This is our approach. The other rule, this comes from the, of course, interventional. We use the transpulmonary approach, so with the median sternotomy and small incision, and we cover completely the PDA with the stent. We don't have problem with stent migration. Our balloon, our stent is the one inflated, is not the one that is released directly by the balloon. 2 patients required additional stent. One was unsuccessful. This was a patient that was bring to the ICU. Then we understand that at the start of the closing of the prostaglandin, there was still some piece of PDA still not covered by the stent, so we bring the patient back and put an additional stent. This is what we learn from our 10 years, and I want to, with Gil Bernowski, recently they published also about the rapid ICU bending. I really trust in this procedure. When sometimes patient is very unstable, no one patient is the same to the other one. We open the chest, we put bilateral bending in the same way, and we don't have PDA stenting. I can say that this became one of our favorite approach in this type of patients. And of course, it depends case by case. For the other patients, we can say again, maximum 3 days after the birth, we use again bilateral bending and bends for patients less than 2 kilograms. Of course, aortic atresia with mitral stenosis and sinusoid, we don't go for now. We do only for transplant. In some cases, we don't have transplant, so we transfer to a transplant center. But for the patient with more than 2 kilograms, we can say that the hybrid approach is, in our experience, the most favorite strategy for these patients. And again, you see that at the start of the experience, we try to do rasking before discharge. So we make the patient become stable and became and to understand which is the impact of the interarterial septum, and depending again about the hemodynamic, we decide or not to do rasking procedure. This 6 weeks rule come from, again, the experience from Professor Garanto. It means if in a patient with hybrid, we have to think to do some additional procedure in the first 6 weeks, like again stenting or adjusting of the band, is better in our experience to proceed for elective Norwood procedure and doesn't go back to the hybrid approach. This is what we learn, and I think it's very important. This piece comes from the archives of Professor Silverman. The sign of 3, when on the echo, you see that there is already a reverse coarctation in the aortic arch. Is better don't proceed with a PDA stenting, because we know very well that this area is very fragile. The flow is marginal flow. It's very difficult to put a stent there without making some flow reduction of the flow. So we prefer in this case only PDA bending without stenting of pulmonary bending without stenting of the PDA. At the start of the experience, this is come from cardiology. We use also to stent the interarterial septum in 5 cases that we really realized that was very important to have free of the interarterial septum, and rasking most of the time it doesn't work well in this patient, because everybody knows that there is a very muscularized system in the interarterial septum of hypoplastic left heart syndrome. I want to go back. Sorry, I forgot. In our experience, we have 78 patients. 72 of them percent arrive to the Fontan completion. So we are very, not proud, but we are very happy of this experience, and we can say for us is we are very happy about the strategy of the use of this technique in this type of patients. This is I want to, before I close the presentation, only to share with you, we use, of course, when you have something that you like a lot, that and you have some patient with a borderline left ventricle, we use the hybrid approach, and this is a study from Professor Oreto that she make a very amazing job about the end-diastolic volume index, Z-score, and Z-score of the left ventricular mass, and Z-score of mitral annulus. And you can see in both group, of course, mostly on the second scheme, there's a patient with biventricular repair. We really see growing process of both ventricles. Most of them, they can say they will grow the same. Yes, I'm sure that they will grow the same. But in our experience, again, the hybrid approach is a 45 minutes procedure, very easy. Patient doesn't suffer cardiopulmonary bypass, and our team, anesthesiologists and of course cardiologists, we really like to approach this patient with this hybrid system. So this is of course the most important point that everybody knows, that I don't think there is a real superiority of Sano or Norwood, because it depends center by center. Most of the people love Sano procedure. I really appreciate them. I still use conventional Norwood with BT shunt, with modified BT shunt, and there is now I think some consensus about the hybrid procedure, because also the big center that have very amazing results with Norwood and Sano procedure, they still consider hybrid procedure an option in low birth weight, and of course as a bridge to decision to heart transplant. My idea is that if you use this approach in patient with a very high risk, the results are, of course, very bad. If you trust in this approach, you have to use this, of course, also in patient not of course 4 kilograms or very stable, or a patient that can go directly to Norwood, but I think it can be used not only in high-risk patients. Again, the center experience is the real most important tools. And we experience this, and of course, we suffer some case and some problem. We learn the interstage is a very important moment for this child. Most of them, some of the time, can remain in hospital for 1 month, or sometimes also 1 month and a half, and we follow them in a very strict way with the red flag about the weight, about the food, about all the pediatric problems that they can have. So I think really that this is a real option for Hypoplas, and of course you have to trust in this approach, and of course you need some learning curve. This is not an approach that you start to use, in my experience, without some sharing experience with center that has already this strategy, because there are a lot of tips and tricks about pulmonary artery, about reconstruction, the patient with stent, the patient that doesn't have stent, and most of the time in the last I can say 5 cases, we don't use more patch for reconstruction of the arch, but we use directly the big pulmonary artery to use to reconstruct the arch. So thanks, Ignacio. I hope that I saw a lot of friends here. Dr. Guzman, send my regards, and thanks a lot again for the invitation. I hope that it makes some sense and will help some of you to understand our approach. Thank you very much.
Thank you a lot, Dr. Agati. This is amazing lecture, very simple, and I think it's a reproducible technique. Thank you again. If someone in the audience to make any question, please, if it's in Spanish, please write in the chat if you want, or go away and talk via Zoom. I have some questions, but I don't know if someone in the audience with any questions. I begin with the first question, Dr. Agati. The first question is, why is the reason that you choose different banding from different branches, because you measure before the branches,
Yes.
and you decide some size.
Yes. I think that I say this in a very straight way because, of course, we saw, and I told before that generally the left pulmonary branches is smaller than the right. And again, this is coming from also sometimes we are able to make to size them also in operating theater, but of course we ask by the echo before, and we realized that most of them with the 3 millimeters of on the right, on the left pulmonary artery, they doesn't have big problem at the time of the Glenn or Norwood or Sano procedure, because this is a right, it was a real right choice. So this is come from numbers, come from observation of the pulmonary branches, and I ask you to look well to your patient if you want to do hybrid, because most of them has the left pulmonary artery is smaller than the right.
The other question that I have is, you keep open the chest after the hybrid procedure, and you adjust a little bit in the next day or not?
No, 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 no.
No.
No, no,
Okay.
no, Ignacio, we close the chest. We close the
Yes,
chest,
exactly.
and I told you. I know that some of you, some experience, when you use this technique in very bad cases, it doesn't
Exactly.
work. It's very difficult to see the real good results, because this
Exactly.
patient you do bending or not, they are very sick. So if
Okay.
you do early, don't wait for big overflow of the pulmonary. They are very stable also in postoperative.
Okay. Okay. I understand. And the when you measure the ASD before the procedure, what is the size of that you decide? I keep open, or you measure the flow. If you see the Doppler some acceleration,
Yes.
how do you decide to make the Rashkin, and what happens if you have a patient with no ASD? You go to this kind of model or not?
Yes. This is an amazing question. This was the main discussion, of course, with cardiologists because of the Raskin procedure. Of course, Raskin doesn't work very well in this patient. Don't expect to have a big results after Raskin. This is the reason why we start at the start. We accept at the start to do also stenting of the septum. Of course, gradient, not sides, is the most important things, because when you reduce the flow, bending the pulmonaries, the gradient most of the time go down. So you have a gradient before that is very unpredictable, but after bending, you see that reducing the QP, you will reduce also the gradient across the pulmonary. Most of the indication, of course, I can say is 10, mean 10 gradient over mean 10, 12 can be a good indication. But what I can share with you that clinically you see very well patients that suffer of obstruction of the interarterial septum. Regarding the closet, of course, this is an emergency. So for closet ASD, we go directly in theater.
Okay. And I repeat, if someone in the audience, please go ahead and ask the question if you want.
Everything was clear.
I have more questions. Yeah, yeah, yeah. But another question is, when is the time to, after the hybrid procedure, when is the time to make the Norwood procedure or the Sano procedure? When you decide? Because if you wait a lot of time, the branches makes little stenosis and produce some problem at the moment of the Norwood. What is the time that you make the Norwood after the hybrid procedure?
At the start of the experience, we wait too much, and we suffer, as you say, that pulmonary branches can become very bad in terms of quality and fibrosis around the bending. So we realize that the best moment is 2 months. 2 months after hybrid, for us, is the best moment that you remove the bending and the pulmonary branches come back very easy.
Okay, and what source of flow, of pulmonary flow, do you make?
I
BT shunt?
prefer, yes, I prefer BT shunt. Sorry, I am very
Okay.
old-fashioned. I don't like.
No.
I don't. We are happy with the BT shunt.
Okay, and what size do you use?
Yes, yes, 2.5 kilograms. I use 3.5 millimeters. Then
Okay.
after this, we use 4 millimeters and 5 millimeters. And if the patient has overflow, we put according to the Birmingham experience, the clip to
Okay.
reduce the BT shunt. But I love good flow to the lung. I can say I never see in my experience, a patient in overflow. Every time I saw a patient that needs more flow in the lung. So the best is for me, go for big and then put a clip.
In resume, if the patient had 3 kilos, you use it 4 millimeters. Okay,
4
If the
millimeters.
patient 3.5, you use 5 millimeters shunt.
Yes, exactly.
Okay, okay.
The last patient was 3.7 kilograms, and we put 5 without clip.
Okay, okay, that's great. And
the only thing I want to say, sorry, Ignazio, one point about this. I really trust in this. I think that the most not difficult, but most cause of failing of Norwood and BT shunt is because when you do BT shunt in this patient, after the reconstruction, the flow on the pulmonary artery, on the
yes, brachiocephalic trunk
artery, is
yes.
Sometimes you have some torsion there. So you have to be very, you have to focus on this, because I think that we clamp to do the suture, to do the anastomosis. This vessel, I think, is very fragile. So you have someone put a shunt before and they put the cannula inside. So I think
Yes.
that the most fragile problem, in my idea, about the Norwood and the BT shunt, that the brachiocephalic is too much manipulated before the procedure, and the anastomosis, and sometimes you have some torsion after the reconstruction of the aortic arch, and the flow is not perfect. In this case, when I saw this, I put the shunt directly in the reconstruction of the aorta, of the arch.
From the arch.
Directly, from the ascending aorta, we can say, like a central shunt.
Yeah. Big shunt, big flow.
I love this. This is my favorite. When I saw that the brachiocephalic is not well, you can see that there is some, problem, some lesion inside. I go directly in the patch of reconstruction.
Okay, that's nice technique.
Yes.
I want to be a picture if you can
I will send you. Yes, sorry,
yes.
I will send. I
No,
am
it's
in
okay.
Iraq. I am in Iraq. So
Oh, okay. And the other, I open the question to the audience. If someone want to make any question, please say hello if you want. I have a little more question if you want,
yes,
Sasha.
please. Yes.
And the question is about when you have a shock, because this technique begin, I remember at Garaham Hospital when I was a fellow, I remember this technique begins with the shock patient that you told in the lecture. And what do you do in this kind of patient? And what do you think if this technique, hybrid procedure, what happened with the tricuspid regurgitation? What do you think? And the last question that I have is, if you measure with any probe the flow, do you know the coronary probes? Do you measure the probes in the branches or not? What do you
Yes,
think about it?
I want to be.
Me dijo que ya había subido, me venía corriendo y era como que había bajado. Sí, el paciente
Sorry.
está abajo. Sí,
Sorry,
sí, sí. De hecho,
there
ahí
are
me está
someone,
preguntando.
hay alguien que tiene abierto el micrófono. Hello.
Yes.
Sorry, Sasha. Sorry. Yeah,
Yes,
sorry.
no problem. You know, we start with the experience come from aortic coarctation. We try to do the flow after correction of aortic coarctation, and we realize that the point it works very well in aortic coarctation, but the point is that in bending you don't really have a systodiastolic flow. You have a sort of continuous flow, and the flow is very unstable. So in our experience, again, we don't really use this technique. What I want to stress on the other side, that if you have a patient in ICU that is unstable or septic shock or things very bad, you open the chest and you only put the bendings and leave the patient on PDA. This is also the experience of Children's Hospital of Washington. You have to, the recent literature, the rapid bending make the patient stable. Of course, you don't treat the disease, but for sure you treat the diastolic flow for kidney, for abdomen. So I think what we learned that in a very sick patient, bilateral blending and stenting and prostaglandin is a very useful and easy approach.
Okay, thank you. And what do you think about the probes, the flow probes?
Yes, I told you the problem is that in the pulmonary branches, we try several things. We try from outside, we put catheter inside. The flow is so small, and most of them are not able to, make a good flow or a good results. This, of course, coming from. I love more saturation, pressure. I'm more hemodynamic rather than. It means trying to keep more information. I understand that, trust me, if you put the 3 millimeters on the left and then you adjust the right slowly, trying to keep your result without inotropes, without extra beat, don't be scared the patient is with low pressure. I think that is something that for surgeon is very important, because you are manipulating only systemic vascular resistance and pulmonary vascular resistance. Of course, the patient, the older patient, 1 week, 10 days, when you bend, they suffer pulmonary crisis. So you have to wait. Don't use nitric oxide. Don't use dopamine. This will make a completely different patient, and this will make a patient very difficult to understand which type of bend, because the problem, the stent is okay. In this procedure, stent or prostaglandin is not a problem. It means that you make an unobstructed systemic flow and everything is okay. The challenging is to find the right bending sides and the right bending position to have a stable saturation.
Thank you, Sasha. Thank you a lot. I don't know, perhaps this is the first meeting.
Yes.
I want to know next Wednesday, Dr. Tarek Alessev from Pittsburgh. He want to talk with us about the complication about the Fontan Kreuzer, and this is a pleasure to work with you, Sasha, for this session, because this is a nice how you give the knowledge around the world, because this is I think the key of the work. If you have some knowledge, you begin with something and some motivation. Thank you again for your work in the work on genital heart association.
Thank you very much.
Okay, keep in touch, and next Wednesday we
yes.
again. Bye bye.
Thank you very much. Bye bye. Bye bye.
Chao.